health plans.
Contextualize something for me before you got into this level of conversation. You were talking about chronic health issues that were typical and the type of ongoing services that would be provided. Mm-hmm. What kind of health issues are we talking about on average, or for example?
I can't give you an example. Would be somebody who's got COPD, severe arthritis,
control diabetes,
and diabetes that's very difficult to manage.
And the services provided would be, for example?
Care management primarily.
What does that mean?
So that means ongoing, so that means first off you do an initial and then ongoing assessments of the individual's needs, their condition and the needs they have related to those conditions, and what services are available to meet those in the community or what you could purchase through MSSP.
I should know all these things backwards and forwards because Debbie Toth makes sure I get updates on a regular basis. But I want to make sure I'm understanding the language that you're using, right. And I know that Ms. Leiker is going to give context for it. Please continue.
Yeah. So what the MSSP care manager is going to do is check in, put together a plan of care for that individual, make sure that the services are in place, make sure that the services that are in place are addressing the needs of the individual, and then monitoring that person on an ongoing basis, either over the telephone or face-to-face in their home, to make sure that the plan of services that they have in place is actually helping that person to avoid being placed in an institution.
Now, you were referencing some arrangements with managed care. Talk to me like I'm someone who has never heard of managed care.
Okay.
And what that really has to do with the MSSP program.
So under current law, in the Coordinated Care Initiative counties, MSSP is considered a managed long-term service and support service. So that's MSSP, community-based adult services, in-home supportive services, and to a degree skilled nursing. So in those counties, managed care plans have to contract with MSSP sites to deliver MSSP services to their enrollees who are eligible for MSSP, and vice versa. MSSP sites have to contract with the managed care plans to deliver those services to their members.
Thank you for playing along and indulging me, Mr. Long.
Oh, my pleasure.
Thank you.
My pleasure.
Did you have anything else that you wanted to add?
Okay. So, just to be clear for everybody in the room, the CCI counties are Los Angeles, Orange County, Riverside, San Bernardino, San Diego, San Mateo, and Santa Clara. Under current law, and there was and San Mateo County. Under current law, MSSP is supposed to transition from being a distinct service with which the plan contracts to being, by December of 2017, by the end of December. After that point, the expectation is that managed care plans have learned their lessons well from MSSP sites and have adopted core components of their model within their own structure. San Mateo has already made that transition back in October of 2015. The rest of the MSSP sites have yet to transition, and we are in the process of working with the Department of Healthcare Services, managed care plans in the CCI counties and MSSP sites, and the MSSP Site Association to develop a transition plan with benchmarks, expectations for local stakeholder process, continuity of care expectations, and rates discussions are part of that to assist communities in making the transition from MSSP being a standalone benefit that contracts with managed care plans to being to managed care plans doing some sort of long-term care management within their existing structure.
Take me one step further about the funding of the programs, and you're talking about the transition. So help me understand the difference between funding, how the programs are funded when they are standalone, contracting with managed care, versus what you were suggesting the transition would look like.
So right now, the MSSP sites receive reimbursement at, for want of a better word, a per member per month rate for every MSSP member enrolled, roughly $357.08, roughly $357.08 per person served each month. That arrangement continues with the managed care plans for each member that they have that's being served by MSSP until December 31st of 2017, or earlier if the managed care plan and the MSSP sites in the community decide that they're ready to transition sooner. After that point, the managed care plans have no obligation to continue to contract with the MSSP sites for services.
So $357 is not a lot of money to do much with, but it's better than nothing. So what happens after that transition? Is there no more funding? Is that...
So this gets into territory that has to do with Medi-Cal rates and arrangements with managed care plans. There's still Medi-Cal funding available in the same amount as is devoted to the waiver through the contracts to the managed care plans. How that funding is allocated within the managed care plans for similar services, I'm not really the person to speak to that.
Ms. Leiker knows. I'm sure she's going to address it in her comments. Did you have anything else, sir, that you wanted to conclude?
I just wanted to update on a few other things that we're working on aside from having ongoing conversations about the transition and benchmarks and so forth and so on. This is a complicated endeavor, and we have been very pleased that the Department of Healthcare Services has elected to bring on a project manager to assist with accomplishing the tasks necessary to have as smooth a transition as possible. So a draft project plan has been put together and shared with the MSSP sites and plans, and we're having, if not weekly, semi-monthly meetings to discuss transition internally and engaging MSSP sites and managed care plans on an ongoing basis to address operational issues that may crop up having to do with such things as information exchange between plans and MSSP sites or reimbursement. And those, we were having weekly meetings. Depending on whether or not there's progress to share, we may meet semi-monthly or once a month.
Thank you. That's very helpful. Thank you very much.
You're very welcome.
Ms. Leiker.
Hi. Good afternoon. My name is Denise Leiker. I'm Vice President of Independent Homoscan Community Service. I also represent the MSSP Site Association. My MSSP site is the single largest site in the state. There's 39 in the state. Mine has the largest enrollment at my current location. I'm grateful to be here today to be able to talk about this because this is a topic that I have been in for 14 years, dedicating my service to the frailest and most fragile in the state. And as you saw with Mr. Long trying to explain this has been a very, very complicated twist and turning landscape while we still, for 30 plus years, maintain in the communities that we serve across the state, we are the resource of last resort for the frailest and most fragile. And I really want to make sure that we pull that out of the description of this population. We're the last stop. Many of them don't have family, don't have any support systems, and our nurse and social worker pull it together for them. So, and doing it, and these people are trying to live out there on roughly $800 a month total. So we're kind of the jack of all trade everywhere we're at. We have 2 proposals before this committee today. I'll take the easy one first, more funding. In the 30 plus years that we have existed, we have only had 2 cost of living increases, only to see those go away with a 22.5% total cut in more recent times when the state budget wasn't doing so well. So we're asking for $4 million to stabilize the program statewide. That $4 million will be matched by federal funds under the 1915C waiver. So that's our first ask. The second item that we bring before this committee is associated with the Coordinated Care Initiative. And it's a little more complex. I'd like to spend my time kind of walking through that, because when we talk about a stronger safety net for our most fragile and frailest, we not only need the funds, but we need the services to actually be there. This is not an experimental population. We get one shot at getting this right for some of these people, because that's the situation that they're in. So for the Coordinated Care Initiative, our ask actually is quite simple. We were here a year ago asking for this committee support and got this committee support, which we are grateful for, in extending the transition timeline that was in state law at the time for CCI. It was too aggressive and so many issues going on the ground, basic implementation, startup complications. When you kind of take what the intent of the legislation is, but you actually then go look at how it's going on the ground, it's been very, very different, very, very slow. I would love to say that we have made a lot of progress in this last year, but unfortunately, 12 months later, we don't have a lot of significant progress in realizing all of the goals that Mr. Long reviewed that are in statute. And that's very concerning to us. But I think we have more insight at the crossroads that we're at right now. One of the big insights we have, the governor actually helped kind of draw a spotlight around it, is even in the governor's budget, he kind of questions the future of CCI and the financial viability. He's now 2 budget cycles put into his budget language around not sure what's going to happen and still watching the program. If you look at CCI is this big, all dual eligibles in the state. For MSSP, we're talking about the far end of the continuum, a very small, the most frail and fragilest portion of the population. So as what we're now able to see very clearly is this is much bigger than us, and we get that. But because the state is working so hard on the whole program and stabilizing the entire model of care, there is no time to do what Mr. Long went over, which was to really dig down and learn, managed care and department and everybody to work together to dig into and learn from what it takes to keep this population safe and in the community to build the next model of care. It's just a lot to do at one time. MSSP right now, our estimate, the association's estimate, is only 6.5% of our population in CCI counties are in the Cal MediConnect benefit, that dual benefit. Your Medicare and your Medi-Cal are together, which is supposed to give you this very much enhanced coordination of care and more resources. The remaining 93.5 are in other categories, and the other categories there's not a plan around them. 6% of that, we estimate, is actually in the fee for service. For whatever reason, this benefit's not available to them. They still have their Medicare and their Medi-Cal out. They're not in managed care. They're not coming into that. So we have a program that in some counties is now kind of split, people that are in managed care and people that are not. And then you have another 87.5% that only have their Medi-Cal in that managed care plan. So we are being paid that monthly capitated rate for them, but there's no mandates, no requirements around what that term is called, the MLTSS population. Managed long-term services and support population, MLTSS. So all it is anything that is eligible to them under Medi-Cal, which would be MSSP, IHSS, nursing facility, and CBAS. Thank you. Sorry, friends, CBAS friends, didn't mean that. So where this whole vision is, the state is going to provide this and managed care is going to provide this comprehensive benefits package that's going to take better care of them and save money. the reality here is our population who we serve and who relies on us every single day to be their lifeline, the majority of them are nowhere in this. So there's this feeling of, wait, don't we need to take a pause? We started this in many counties October 2014. Some started a little sooner than that, and Orange started later than that. But maybe it's time to take a pause and look at the whole picture here. Maybe we shouldn't be in there right now until they get it right, until they perfect the benefit, till we know what's really going to be there. Because the time pressure and constraint to try to figure all this out and catch up and get it all done, the clock is going to keep ticking on statute. So we are looking for support to really look at taking a step back with this population while they finish stabilizing Coordinated Care Initiative, CalMedi Connect, the enrollment, and all of those other pieces. Take the pressure off for such a frail and fragile population. Pull us back out, carve us back out for now. And when the program is ready and all of the pieces are in place, bring us back in at that point. This is really important for the people that we serve. So that is our request, is both funding and the support of keeping this safety net even in the CCI counties. Thank you.
Thank you. Would you just say a little more about what this all means for the individual served? And so you talked about only small percentages of people served fitting into certain categories and others are not. How does that translate into, what does that translate into for the experience of the actual individual served at the end of the day?
So I was asked a similar question recently, and this is how it was asked to me: what has changed from my staff? What has changed in our service delivery on a daily basis? And the only significant change to how we did business before this ever existed is that we have a much higher administrative paperwork burden. We are now, my site is a great example, where before I had to only bill the state of California for my clients, I now have to bill the state of California for 6% of them. And then the rest of them, I've got to bill across 5 different health plans. I've got to generate 6 different invoices. Now remember, my N is 755. So the administrative burden there, the administrative burden of uploading all of our documents to the health plans, that's all there. But the delivery of care and the service has not changed. It's not at all. My staff is still doing it all for those clients. They're still calling us. And at my site, I've only got, out of my 755, about 40 people that are in the CalMedi Connect benefit anyways. So for all those other people, the plan's not there for them anyways. That they're coming to us, we're doing it all. We're navigating the health system for them. We're making sure they're eating. We're making sure that they're getting their rent paid. They're getting to their doctor's appointments still. So the experience that we are seeing, nothing's changed. We're not getting calls from the health plans on these members to coordinate. It's not there.
Got it. I don't know if this is for Mr. Long or Ms. Connolly. I don't understand what all of those letters were that you said last time, but
Sorry?
I do understand what it means to have to bill 6 or 7 different health plans and bill the state for reimbursement. And I know that for nonprofits, that means a great deal. And I do want to understand if there is a vision for how to streamline that so that agencies don't find their resources so thinned in trying to meet administrative burden that it begins to impact their ability to provide the actual direct service. What's the vision for how to make this become more seamless?
I can't speak for the Department of Health Services. I can say that part of the reality of this transition right now is that managed care plans have to have contracts with MSSP sites. And there has been discussion about how to have a sort of core approach to billing across plans, but I don't know that that's been resolved. So that, and what I mean by that is that there wouldn't be a single window, but at least what's being submitted to plans would be somewhat similar, in the same way that there has been a discussion about providing information about people enrolled. So that's about all I can say in terms of a vision on simplification.
So there's still always going to be an issue when you have multiple entities, like 5 different health plans. They all run a different computer system. So even if the form looks the same, we have to interface electronically with them. And that there's no way, I don't think the state can mandate one way into the plans. I mean, if we just went back to billing the state, that would be one great solution because it would go back to that one single source. But as long as we're having to get paid by all these health plans, you're never going to really necessarily simplify that, because that would mean that every health plan has got to be running a similar technology system, and you're not going to be able to regulate that.
Anyone here from Health Services? I know they're listening. Anybody here? We'll save this. We will save that question for when we are next with them. It's helpful context. We're not agendized to take action on the proposal, but it is helpful. Question from Mr. Chu.
Just had one question, and my apologies that many of us are having a very busy afternoon. I was voting in another committee and had 2 other bills to present. I know Mr. Thurman is in the same boat today, as well as other members of the committee. So in the last year, I have received a lot of requests from constituents around the so-called village-to-village model. And I know that, hopefully get the acronym right, MSSP is focused on our most frail, whereas the so-called village-to-village model, of which there are now a few hundred in the country, are really focused on seniors who are much more physically able to carry on their lives but need more assistance. Could you talk about how, from what I understand, there's nothing really that the state is doing in that area, even though there are increased requests for funding. And I'm wondering if any of you could comment on that, or if there's a relationship between that and this program.
Do you want to talk from the local perspective?
So no idea on the state level, but on the local perspective, I know down in the Long Beach area that actually there's a consortium coming together to look at the village for the low income, the more towards the MSSP population. You're right. Most of the village concepts are because you pay a fee to live there, and they're in higher functionality and higher income. But because housing is such a crisis, and I know my site has been engaged because of our competencies in this area as part of that committee, looking at could that village type of concept work for this type of population, or what I would call the pre-MSSP, that maybe those that are not quite as frail yet for nursing home certifiability, but are definitely low income and are definitely starting to struggle, could maintain, and they would want to bridge out some of the community expertise for that. And so we are seeing a little bit of that at the local level.
Yeah, and my understanding in my district, I have a few of them. There are at least a few dozen in the state of California. I've been encouraging them to get together and hopefully start engaging us in conversations, because we know, just as with this program, there are cost benefits if you intervene early, and that's what I understand to be the case also with the village model.
And I would just say that the challenge, I think, in talking about the village model is everyone is unique. But just to kind of expand out, I think in a large part, a lot of the interest in the village model is also we're talking about the Medi-Cal population right now, but for older adults who don't meet Medi-Cal eligibility, they still have lots of challenges in terms of navigating the system, trying to figure out how they're going to piece together resources if they've just had a hospitalization or whatever. So in every community, I mean, we've had conversations with a number of emerging or developing village models. Some of them are really neighborhood based. Even in San Francisco, there are different models. Others are, more focused on a target population, but really working, together. And I know a number of the area agencies on aging in those areas are also, certainly part of those discussions and kind of development pieces. A number have received foundation support to kind of get going. But now are kind of at that stage, again, if they're not for low income or mixed income, really, trying to develop some kind of funding mechanism to support themselves and sustain their growth. But
I appreciate that, and I think I've been encouraging them again to come up here to Sacramento, and I think probably next month I was just going to say, I think fairly
there's
significant gathering.
A hearing being
and I love if possible, I'm happy to facilitate a conversation with Department of Aging and others to see if there's something that makes sense in that area. Thank you.
Thank you. Let's hear from Finance. Anything from Finance? Anything from the LAO's office? Is there any public comment?
Good afternoon, Mr. Chair. Gary Passmore, Congress of California Seniors. If Mr. Chu needs to leave the room because he's got delicate ears, he should. You're one of the few members of this building that I'll talk to like this. I want to cut through the bullshit on this issue. MSSP was one of the best programs that the state had to try to keep really, really frail, delicate seniors and people with disabilities out of an institution, which saves tens and hundreds of thousands of dollars each year. They did it by personalized care and approach. They reached out, they touched, they had professional people like social workers and like nurses. And the decision was made when we created the CCI, which I have strongly supported because everybody needs care coordination, which is what they do to a fault. The program was somehow going to be phased in to CCI, and the plans were each going to figure out how to resolve it. Well, let me tell you what some of those plans are doing. There's one major plan in this state that can't even schedule the first care coordination appointment after 4 months of trying to reach somebody they get paid for every month from Medi-Cal and Medicare. They can't even get them on the phone or to answer a letter. Now, my experience with MSSP is that they would have probably been at that door within 5 days. And if there was a problem, they would have fixed it and then connected those people. Having a phone bank of people with 6 or 8 weeks of training to handle care coordination, which is the kind of care coordination people are getting, isn't what MSSP does. And we need a moratorium about transitioning them and making them disappear.
So I'm clear, sir. You're saying that you don't want MSSP in the CCI? Is that what you're saying?
I am saying we need...
Give me your point. I appreciate the passion, but let's keep the core.
I am saying we need to rethink and completely recalibrate this inevitable calendar-driven transition until we know what we're doing.
Thank you.
Thank you.
Thank you.
Hello, Chair Thurmond, members of the committee. I'm Debbie Toth. Still, you missed my first presentation. It was short, sweet. This one, you might have to cut me off. But I feel like I'm going to go off script here because there needs to be a little explanation. With care coordination gets bandied around a lot because the hospitals do it and children's social workers do it and lots of different people do care management and case management. And what MSSP does is go into a home. I'm going to talk about in Richmond. And we look at the refrigerator, we look under the bed, we find medications in the bathroom, under the bed, in the kitchen, in the refrigerator, on the bed, in a shoebox, and the grandson's stealing them and selling the Vicodin on the streets. There's rats, there's cockroaches, there's rugs that are slipping and fall risks. This person can barely walk. They have diabetes, they have Alzheimer's disease, they have about 5 other chronic conditions, and they have 17 different medications, and they have nobody who's monitoring their care. MSSP goes in and looks at all of that and says, we're going to get you to and from your doctor's appointments. We're going to interview and train your in-home support service workers and make sure they show up on time. We're going to put grab bars in your home. We're going to remove those rugs. We're going to get nutrition to your home. And we're going to make sure that you don't end up in a skilled nursing facility, which costs the state significantly more money. So MSSP is not a hospital-based case management program, and in order to be able to understand why it's important to provide those services in a community-based way, I want to just give an example of if you were a pastor in a church, would you allow the hospital to provide your services there? You would ask that they have a pastor there for somebody in the hospital who needs them, but you wouldn't expect that pastor to go into the community, lead a congregation, go into their home, figure out what their needs are. That happens in a community-based church, not in a hospital-based church.
What we should be doing, Ms. Toth?
Pardon me?
Frame it for me so I hear what we should be doing.
We should be stopping the CCI portion of MSSP, and we should be funding it adequately so we can continue to save the state dollars and have people age in place as they should be. Thank you.
Got it. Thank you. 1 minute each speaker.
Hi, I'm John Balutz. I'm president of the MSSP Site Association and also executive director of the Health Project Center, and I run MSSP programs for Santa Cruz and Monterey counties. In a survey of MSSPs around the state, 2/3 of the members said that they cannot serve all the clients that they're contracted to do on the existing funding we receive. In 10 years, we're getting the same per person rate that we got 10 years ago, and that, in the end, does affect quality of care. Our vendors, 30% of what we do is purchase. Their prices go up. We have to compete in the marketplace for social workers and nurses. When we have turnover or can't recruit the best people, that harms quality of care. The cost of health care has gone up dramatically over the last 10 years. We've had it flat funded and really cannot continue on that. My second point is let's get CCI right. Then let's have MSSP join it. We cannot experiment with this group, and we really need to make sure we have a solid foundation before we bring in MSSP into the CCI. So thank you for considering this.
Thank you.
Thank you. Jordan Lindsay with the Senior Services Coalition of Alameda County. And while not a CCI county, of course, do definitely support increased funding for MSSP.
Thank you.
Nancy Marish with the Congress of California Seniors. We've thrown around a lot of initials. We've talked about pennies, nickels, and dimes. But the three letters that someone who is eligible for MSSP wants to hear is YES. Yes, I can help you.
Well stated.
Please support.
Thank you.
Good afternoon. My name's Carol Eccles. I'm the director of the MSSP site at the City of Oakland. And I am here to ask you please to support increased funding for MSSP and also to support a carve-out for MSSP from the CCI. I would like to give you a little personal story about MSSP. Many years ago, I applied to be a case manager in MSSP and at the City of Oakland and did not get the job at the time, which was fine because I certainly, went on and continued to work elsewhere. And then I got a call one day, and someone from the City of Oakland wanted to know if I would be interested in being the site director of the MSSP site 30 years later. And it also turns out that I had a very personal history with MSSP because my mother had been a participant. She was a participant during the time when I was raising my son, who was a teenager, young adult age, and working as a single parent and living the sandwich life of being between aging parents who were failing and having this young man in my home. My son is here with his daughter today. We were able to keep my mother at home with us, and I was holding her hand when she died at age 96. And I could not have been able to do that and be there for her peaceful passing without the help of an MSSP program. So I have a great dedication for this program, but we cannot continue to service the people that we need to if we don't get an augmentation in funding. Thank you.
Thank you. Thanks so much.
Good afternoon, and thank you, Mr. Chairman. You happen to be my assembly person from Contra Costa County. I'm Dr. Barb Porter, and I'm the site director at an MSSP program in Contra Costa County. I don't want to be a doomsday person, but I'm going to say something that is absolutely breaking my heart, and that is I receive 4 to 5 phone calls sometimes a day, people begging for the services of MSSP, and we can't meet them. You have no idea what it's like to get somebody on the phone saying, my mom fell out of bed, she's incontinent of bowel and bladder, she laid in her feces all night, nobody was there really to help her, can't you please find something? So we're locked into a program. Of the people that we serve one of the smaller sites. We have 160 people. We can't quite make that even work because the vendors are going up. I just got we're in contracts with our vendors. We have a care provider who said, I'm going to raise your rates to $31 an hour. IHSS only goes so far. We've got people that are totally bedridden and need help over the weekend. So I'm begging you, and I don't usually get on my knees and beg, but I'm saying restoring the funding because we've got a tsunami coming in terms of the elderly population. There's got to be a way of taking care of the people who raised us with dignity and respect going further. Thank you so much.
Thank you.
I'm Susie Goodman Goldstein. I am with the MSSP program in San Francisco at the Institute on Aging, and we serve 446 San Franciscans. You must restore this funding. Our clients are the people who were firefighters, teachers. They don't have the money. And they need to be able to live with dignity in their community, and this is a community where housing is an issue for everyone. You need to restore the funding so we can keep these people and help them live to 100.